Hello Health on LAE is presented by the Ochsner Health System, a nonprofit, academic, multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 7 hospitals and more than 35 health centers located throughout Southeast Louisiana. Ochsner, healthcare with peace of mind.
We call it our More Money to Spoil Our Grandkids plan. With a Humana Medicare Advantage health plan, we get tips on how to make our money go further. We even get a health, finance, and benefits statement called Smart Summary that helps us find even more ways to save. And we like more.
More of what you want, because you deserve more.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with LAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight's topic, genetic breast cancer screening and how it could save your life. Our guest is geneticist Dmitriy Niyazov, the section head of medical genetics for the Ochsner Medical System. As always, we begin by introducing you to our guest. Dr. Niyazov started his medical education in his native country of Uzbekistan, once part of the Soviet Union. He relocated to the United States, where he graduated with honors from the University of California in Los Angeles. He attended medical school at the University of Rochester School of Medicine. He completed his internship, residency, and fellowship at the Emory University School of Medicine in Atlanta. It is our pleasure to welcome Dr. Dmitriy Niyazov to Hello Health. Great to have you on the program, Doctor.
Pleasure to be here.
Thank you. Well, let's begin with how old were you when you left Uzbekistan, and at what point did you decide you wanted to study medicine?
I was 19 at the time, so about 16 years ago, and I decided to study medicine way before, about middle school. And in the U.S., I just wanted to complete the training and be a doctor.
Let's take you back to middle school. I'm not sure many middle school students think I'm going to end up in medicine. They may find it interesting, but you knew at an early age that medicine was something you wanted to pursue. What was it?
I just loved the physiology and the anatomy as a part of the science. I just figured, humans are the most complex animals, so I would give them a try first, and signed up for a local clinic as a volunteer in the orthopedic department, and reduced a couple of fractures, took care of a couple of bleeding patients, and realized this is really what I want. There was some elimination process as well, but overall, I thought this was a great field, and I still think so, and I will.
Once you decided on medicine, you thought you wanted to be an ear, nose, and throat physician, but as it turns out, that wasn't the way it ended up. Tell me that.
Yes, it was not a good choice, as I figured out probably 2 years into my residency, and rather than just toughing it out and being miserable, I decided to go into research instead, think about whether I want to do another specialty. And then the research is where I found that genetics is a great field and it has a lot to offer. It really literally permeates every single medical specialty and even more other professions. So I'm here and I'm happy.
Dr. Niyazov's other areas of interest include autism, mental retardation, congenital anomalies, prenatal and cancer counseling, and adult genetic disorders. But tonight we'll be focusing primarily on genetic breast cancer screening and the advantages of knowing your predisposition to develop breast cancer and what that could mean for your survival and improved treatment strategies, and we'll be talking about all of that tonight. Well, doctor, let's start at the beginning. Exactly what is genetic breast cancer?
First, I'd like to make sure the terminology is clear. Most people refer to genetic breast cancer as the one that is inherited from one of the parents. and that is what we call hereditary breast cancer, and this is what this is all about. Genetic breast cancer, by definition, is the cancer that is caused by other genetic factors, which there are many, and not all of them are inherited. We care about finding the abnormality that one of the parents passed over to the patient, and see how we can use that abnormality to increase survival and to offer more effective treatment options.
Go ahead, I'm sorry.
I was just going to say, as you know, there are about 10 to 12% of all women in the United States that will have breast cancer by the age of 70. And out of most of those cancers, sporadic is the one that seems to be the most prevalent. And that's where environmental factors are mostly at play. Then there is what we call familial cancer, and that's in about 10 to 20%. That's where you have several family members affected, but they're either distant relatives or they're even close relatives, but their age of onset is late, above the age 50. And then you have that 5 to 10% category of hereditary breast cancer, in which you have many family members that are close relatives, first and second degree, that have the age of onset that is below the age 50. Well, that category is rapidly increasing because we are able to test more and more of the genes and find more and more genes that are responsible for hereditary breast cancer.
Further point of reference, breast cancer is the second most common cancer and the second leading cause of cancer for American women. 210,000 American women will be diagnosed with breast cancer this year. Doctor, why is it important to understand the genetics of breast cancer? And you brought some images to walk us through this.
I think it's important for the public to realize what's at stake. Why is it that the genetic breast cancer is occurring early? Why is it that it's deadlier? Why is it that it's increasing mortality and shortening the lives more so than just sporadic cancer or regular cancer? And it has to do with really how the hereditary versus sporadic cancer occur. So in a sporadic cancer, you inherit normal genes from both of your parents that are important in breast cancer. And it takes first one gene to knock out in the tissue, like breast tissue, and then a second gene. So you have two chromosomes, one from mom, one from dad. So both of those genes are knocked out. And then the tumor develops. And that requires 3 steps. So normal gene, 2 normal genes, to 1 normal, 1 abnormal, to 2 abnormal, and to the tumor. So 3 steps overall.
So as we look at this image, what should we be looking for?
We basically are looking for the comparison between then the hereditary cancer, where you already have 1 gene abnormal that comes from one of the parents. So all you have to do is just knock out that second gene, and then the tumor grows and nothing stops it. And that's what happens when you have 3 steps versus 2 steps. 2 steps are easier to achieve, they're faster to achieve, and that's why you come down with the cancer earlier and you die earlier.
How do you determine a person's risk for hereditary predisposition to developing breast cancer?
Well, there are a number of red flags. First and foremost is the age of onset. And when women come to me for counseling, they tell me frequently, my grandmother or my mother or my sister developed the cancer before the age 50. And that's where we're looking as a red flag. Or the woman herself developed it before the age 50. The other possible indicators of genetic breast cancer is breast cancer in men at any age, because about 1% of all breast cancers are male breast cancers. And because they're so uncommon, if you've got one, there must be some genetic predisposition. Any age ovarian cancer also is looked at as predisposition to, and now we're looking at hereditary breast and ovarian cancer syndrome, because the same genes, as it turns out, can predispose you for 2 different organ cancers, like in this case, breast and ovary. If you have Ashkenazi Jewish ancestry, that tends to be a genetic predisposition and higher risk there. And of course, multiple family members that are affected with cancer, that's a red flag by itself. And most of the time, as a part of my counseling, I actually ask my patients to go and find out more about their family, 2nd, 3rd, 4th generations, because sometimes that's helpful.
What risk is there if you determine a patient has hereditary predisposition to breast cancer?
So, as you can see from the graphs there, you will have about 10 to 12% of all women will develop breast cancer, and then if you have genetic predisposition, up to 87% women will develop it by the age 70. If you have ovarian cancer, then only 1.5% of women develop it by the age 70. But if you have genetic predisposition, you're going to have 44% chance of developing ovarian cancer, which is actually more dangerous to have in many circumstances. Then you have in men, actually what I'll concentrate on is the other cancer. Also, there's a higher predisposition. If you have something like BRCA1 or BRCA2 mutations, those are the genes. And colon cancer can be increased in risk from 6% to 12%. Melanoma and pancreatic cancer may increase in 2 to 4 folds. But primarily, of course, it is breast and ovarian.
What does typical surveillance for breast cancer include in any woman? So not someone who you're necessarily looking, but just the typical screening and surveillance process.
Yeah, so most women are aware of that 18 years of age is where the recommended age is to do a monthly self-breast exam. And starting the age 50, women should have clinical breast examination by a doctor yearly. And then also starting age 50, it's mammogram, and most women are familiar with that.
Knowing that the first red flag you had listed up was anything under 50 years of age, as someone who is so closely, so very knowledgeable about this subject, if breast cancer runs in one's family, would you recommend that those mammograms begin before the age of 50, where there is a family tendency to developing breast cancer?
What you're referring to is familial breast cancer, not necessarily the one where we can test and prove that the person is predisposed. But there's enough family members that are affected that we could say there is a higher than general population or sporadic risk. And yes, at those instances, I do recommend to start at 40 rather than 50.
Okay. What is the surveillance in a woman with hereditary predisposition to breast cancer? How does that change from what we just talked about?
So self-breast exam pretty much doesn't change, but
still at 18.
It's still at 18 and the monthly. But clinical breast exam and mammogram from 50 now jump down to 25. And the early surveillance is really the key to pick up the cancer early and to treat it and cure it. And then there is that other dimension that comes in as breast MRI, or magnetic resonance imaging. And what I found is that many women who come to me for counseling are not even aware that that kind of modality exists out there. Everybody talks about the breast self-exam, clinical breast exam, ultrasound, or mammography. But MRI is relatively new, and it increases significantly the sensitivity of the mammogram. And if you want to bet to find that cancer as early as you can, MRI will be of a great help. But of course, every time you increase sensitivity of the test, your specificity goes down, and you can have more false positives with MRI, which means frequent fine needle aspiration that are MRI-guided aspirations and false positive results. And it can be frustrating, but then On the other hand, what would you rather choose? Would you rather choose false positives, or picking up the cancer that is not there, or missing the true cancer that can then go on and cause you a great deal?
So has MRI replaced mammograms as the gold standard, or no?
Not at all. And that's because it's not studied. It hasn't been studied as well as mammography. Mammography has been in for years. There's been many studies. It's very solid. MRI is, of course, socioeconomically much more difficult, and insurances can put up more fight with that, and you can't really use it on a regular basis when you're doing sporadic cancer surveillance at the age of 50. So no, we're not there yet. Probably we won't be there just because it's a very expensive technology, but it will be as an adjunct to specifically hereditary breast cancer surveillance.
Is there screening to see if a man is predisposed to developing breast cancer?
Yeah, so thanks for pointing it out, because men can have, less than 1% of men will have breast cancer, but about 1% of all breast cancer is seen in males. And when you have genetic predisposition, especially with BRCA1 and BRCA2 genes, then men will have up to 7% risk of having breast cancer.
Rather than 1%.
Rather than 1%. So it's about sevenfold. And you still have a chance of 93% chance of not having it, but the problem is if you do have that breast cancer that is hereditary, in men it tends to be less differentiated and more aggressive, and prognosis is poorer than in women of the same kind of grade and consistency. So the recommendation...
How do you screen, right, as we look at there on the screen?
Exactly, and the screening guidelines, they have not been fully worked out yet, and the reason is because there aren't too many men having cancer. So it's hard to run large-scale studies like we do on women, and then evaluate efficacy on large number of patients as what particular modality worked. And the ones that you see on the screen are merely based on what we see mostly in women, and also involve self-breast exam, clinical breast exam, mammography, and ultrasound perhaps on a yearly basis starting at age 40, but only if clinically indicated. We don't have good data that suggests a certain efficacy of a modality like in women. We know that mammography is sensitive and it is effective, and MRI is effective as well. We just cannot predict that in men quite yet, and sometimes something like mastectomy is what is chosen to be, although there's still no literature supporting that.
If you determine that a patient has hereditary predisposition to developing breast cancer, what do you do then? What are the options for patients? So
the key things that we need to do and we need to discuss is surveillance, chemo prevention, and then prophylactic surgery. Surveillance we've just discussed greatly increases the likelihood that the cancer will be picked up and treated early. And in prophylactic surgery, something like prophylactic mastectomy.
What about chemo prevention first, before we move
would
on?
like the chemo prevention. There are several agents in the market. The most common, the most well-known one is tamoxifen, or there's another drug that's kind of in the same group called raloxifene. And that is effective for breast cancers that are estrogen receptor positive, and reduces the risk for developing cancer about by half. And then there is another set of drugs called aromatase inhibitors that are more recent kind of invention, such as Arimidex is one of them, and have been recently also proven to be effective and decreasing the chances 50 to 70% of the time.
Very good. And let's go back to prophylactic mastectomy. That's certainly one of the options.
Yes, so that's by far the most effective way of preventing breast cancer, and it kind of makes intuitive sense, is doing bilateral breast removal, and then you can do reconstruction either with abdominal muscle or with implant. That reduces more than 90% chance of having breast cancer with bilateral prophylactic mastectomy. And then we have prophylactic oophorectomy, which is a removal of the ovaries. And not only that gives 96% reduction in the risk for ovarian cancer, it also gives about a half of it, even up to 70% risk reduction for breast cancer.
And why, you've already talked about the genes being similar, maybe the same family, but draw that line for us, that connection.
Sure. The genes, let's take BRCA1 and BRCA2, or we call them BRCA1 and BRCA2. Most in the population, most women refer to it as BRCA1, BRCA2. They're the genes that would increase the risk for both breast and ovarian cancer, the so-called hereditary breast and ovarian cancer. Why is it that they work in so many organs? Is because the mechanism of how they work. They are called tumor suppressor genes. There are several mechanisms in our body to make sure that the cancer either doesn't occur, or when it occurs, it's stopped right where it is. One of those mechanisms is the immune system, for example. Well, another one is tumor suppressor genes, where they produce a gene product that arrests the cancer and doesn't let it grow. And those tumor suppressor genes are active in several different organs, and they work by similar mechanisms. So BRCA1 and BRCA2 are active in breast and ovary, and BRCA2 is also active in pancreas and skin cells. That's why we increase the risk for melanoma. So that's why you have same genetic predisposition, so-called same, but evolving different organs.
Let's talk about treatments we may see in the future.
So these are right now already tried, and in the direct-to-consumer marketing and advertising, so-called personalized medicine, and what they involve is a unique gene expression profiles. It's a unique signature of that particular individual, of her breast cancer, that is different from even her sister's or her mother's cancer. Well, we talk about, well, it's the same gene mutation that is passed on from the mother to the daughter, so we've got to have the same breast cancer. Well, it doesn't really happen that way, because you can have the same predisposition, but because of the environmental influences, but then more importantly, because the other genes of that individual, the interaction of the genes, will give you a different behavior. Even if it's the same cancer pathologically, it can give you different behavior. It can also give you different sensitivity to the chemotherapy agents. And what these new treatment strategies do is to find what is that unique signature that can allow me to attack that particular cancer in that particular individual more effectively than in anybody else, even with the same mutation.
Talk to us, doctor, quickly about genetic counseling in this area and what that involves.
Most of the time when I receive referrals for counseling, they come from either medical oncologist or surgical oncologist. And those are women who recently were diagnosed with breast cancer, or who have extensive family history. And in those cases, they could straight come from the internist or family practitioners. And when I have the counseling session with my female patient or male patient, but of course more of them are females, is I sit down and I go over the medical history and personal history, and things such as when the menstrual cycle started, when the menopause began, how many children the woman had, if she's used birth control. All of these are potentially modifiers of the cancer, both breast and ovarian. Then I go, of course, over the family history and typically do 5-generation family tree. And it is sometimes very important for me to get the specific details, even if it's not first to second generation, but third generation, because I can see the pattern and I can see the ages of the individuals with cancer. Occasionally, I will actually have to ask my patient to either find out more information about family history, or they can sometimes call right in my office and I can talk to their family member. And they can tell me, well, I had already testing done. What kind of testing? Well, BRCA1, BRCA analysis. Well, do you know the results? Well, they said it was normal. What kind of testing that was done? Can you send me the report? That's very important because I don't want to repeat the same testing on my patient that was already done on the sister. We don't want to give them two different diagnoses.
By the way, the test involves, it's a simple blood test. That's the test that you take. The results can take several weeks, though, because determining genetic breast cancer or the predisposition for that can take much longer and is very detailed, and we don't have time to get into that tonight. We have about 30 seconds left, Doctor. How much does the testing cost, and is it covered by insurance?
Yeah, it costs $3,700 for BRCA1 and BRCA2 at Myriad Genetics, and then it costs about $1,300 with City of Hope, and that's a different gene called CHEK2.
Dr. Dmitriy Niyazov, we thank you for the education you have provided. A very interesting time here tonight as we learn from you and for your good work that you do at Ochsner. Thank you so much for what you brought to the program.
Thank you for inviting me.
You are very welcome. Well, we want to look at what's coming up on Hello Health here in the rest of October. On Monday, October 26th, oncologist Richard Van Langendonk joins me here on LAE to discuss advances in testicular and prostate cancer. That's here on LAE. And on Wednesday, October 28th, Dr. Claude Williams will be at Ralph's on the Park restaurant just across from City Park. The topic of his presentation will be hand and arm pain. To make an appointment with any Ochsner physician or to learn more about upcoming Ochsner Hello Health seminars or to get a hold of Dr. Niyazov, you can call Ochsner at 504-842-5669. And that's a special number set up just for this program. That's 504-842-5669. As a reminder, you can re-watch tonight's presentation or any of our Hello Health programs on our website at WLAE.com or on Ochsner's website at ochsner.org. Just type in Hello Health in the search areas. You can share the program with people you know. Our thanks again to tonight's guest, Dr. Dmitriy Niyazov, to Ochsner and Humana for making this program possible. And our final thanks, as always, is reserved for you, for your support of our program, Hello Health, and our station, LAE. More than television.
Hello Health on LAE has been presented by the Ochsner Health System. 600 physicians in 80 medical specialties working with a team of more than 10,000 employees to provide nationally recognized health care across Southeast Louisiana. Ochsner, healthcare with peace of mind.
I call it my I've got a healthier plan. With the Humana Medicare Advantage Health Plan, I get more health and wellness options like fitness programs, health management classes, and a 24-hour nurse line. I can even talk with a Humana Market Point representative whenever I need to. More of what you want, because you deserve more.